I'm going to be talking today about how we can design pharmaceutical pricing policies to promote population health in the long run. So this is a disclaimer, but it's also a useful opportunity to mention our policy research program, which is funded by our NIH, the NIHR in the UK. And this work was undertaken as part of that policy research program, and I'll provide a link to the website, as we do a lot of very policy relevant economics work in the health space via that unit. Okay, so I'll give a brief background on pharmaceutical pricing. So new branded pharmaceuticals have a period at the start of their life cycle where they have intellectual property protection, and that allows them to command high prices at that point in their life cycle. And this is by design to encourage and support innovation, predominantly by private companies. So those might be companies in the pharmaceutical industry and also the biotech industry. And when this period of protection from competition runs out and medicines become older, they're expected to face price competition from generic substitutes, or if we're talking about a biologic, from biosimilars. So the policy context for the research we've been carrying out here in York is that there are these long-standing concerns about whether we're getting value for money from our pharmaceutical expenditure, and whether also we're appropriately supporting the life sciences sector and incentivizing the innovations of the future. And concerns have been raised that the way we think about pricing and the market for medicines and how we might regulate that in different ways, they don't think about this life cycle value. So this idea that a drug can deliver value for much longer than its patent protection period, because we expect to get those generic or biosimilars in the long run. And that current approaches to thinking about price regulation also don't consider how different pricing policies and different features of the market for medicine impact on the incentives for innovation, which is obviously key to ensuring that we've got a supply of drugs available in the future. And so this research set out to integrate both of these considerations and to hopefully provide insights to inform those developing and designing pharmaceutical pricing policies. So, of course, the market for pharmaceuticals is a global one. And we have taken a global perspective when we've thought about these issues, as our work was motivated by funding and engagement with the health care funding bodies and also the Department of Health and related bodies in the UK. We do have a lot of UK illustrations in this work. But I'm also really happy to be able to share today some work in progress from ICER. So that's the Institute for Clinical and Economic Review, which is specific to the US context. Okay, so I'll give a very whistle-stop tour of previous research in this area and what it's concluded and what we thought were some of the limitations of that and why there needed to be some further research. So a lot of the research in this space has concluded that manufacturers should be rewarded the full benefits of research as they face the full costs. But this makes some quite strong assumptions that the periods of intellectual property protection that are awarded to new pharmaceuticals are in some way already optimal. And that seems, perhaps unlikely to be the case across all products, and particularly because intellectual property protection is set at a much broader level than even just thinking about pharmaceuticals. There is also a body of work that's looked at the dynamic effects of price and also patent policies, and looked at how they're likely to impact on the stock of future innovations. But this work hasn't accounted for what we call health opportunity costs. And I'm going to go on to talk quite a lot about what I mean by that over the next few slides. And finally, there's also a set of, I guess, perhaps more European focused research that has really focused on this question of what are these health opportunity costs. But this hasn't accounted for those welfare gains, those benefits we get in the post-patent period because products are available much more cheaply. So in order to think about this problem, our first building block is to think about the life cycle value of a medicine from a population health perspective. So this has really got two components. We've got health benefits associated with using the new medicine. Now, I'm going to talk today a lot about QALYs. So these are quality adjusted life years. It's a general measure that reflects survival benefits and morbidity benefits from medicines. But our work isn't contingent on that, and you could replace QALYs with another measure of health that you might think is more appropriate. So we've got those benefits from using the medicine. On the other side of the equation, we've also got the costs. So we've got the costs associated with using the new medicine over the period over which there is that intellectual property protection in place and sometimes beyond. The costs associated with using the generic or biosimilar version as and when that becomes available, and then other healthcare costs or savings associated with using a new medicine. So that might be things like the cost of administering the medicine or savings because the medicine improves an individual's health condition. But a key part of this is thinking about, well, how can we think about the health consequences of those costs? And that's what we refer to as health opportunity costs. So this is how much health we could have got if expenditure on a new product was allocated to other healthcare priorities. So that might be to increasing the number of healthcare workers, it might be to investing in screening or diagnostics or some form of consumables, other ways we could spend that money. And for the UK, we use an estimate of £15,000 per QALY to think about how much it costs the UK to generate 1 unit of health measured in QALYs. And we use this because that's the measure used by the Department of Health. And what this means is that every £10 million we spend on a new pharmaceutical, we can estimate that that would generate around 700 QALYs if it had been allocated to other forms of care. And so it's really helpful to be able to translate costs into health opportunity costs so that we can look at the overall impact of funding a new medicine over its life cycle. So we can look at, on one hand, those health benefits, but on the other, those health opportunity costs associated with funding the product rather than other healthcare priorities. So one question that often comes up is how relevant are health opportunity costs in different types of health systems? So in the UK, perhaps it's pretty clear cut. We have a tax-based funded healthcare system that operates in broad terms as a single payer. And so it's quite clear that however the budget is set for our national health system, our NHS, if we spend money on pharmaceuticals, then that money has to come from somewhere else, and that has opportunity costs. It's perhaps less clear in other systems. And so, for example, in the US, I think it's fair to view Medicaid, Medicare, and the Veterans Administration as single payer systems with some similarities with the NHS, in that however funds are raised or whatever the budget size is for those organizations, the dollars can't be spent twice. And so the opportunity cost of the healthcare dollars is the health forgone as we spend money on medicine rather than other forms of care. When we think about private health insurance plans, it's somewhat more complex, and I think there's several pathways through which increased spending on pharmaceuticals might be expected to impact health. Perhaps the most obvious here is that if we have higher co-pays, we may see reduced usage of medicines that are needed, as patients don't go and file their prescriptions. We may also see that as costs start to go up, employers no longer offer insurance, or employees no longer decide to buy coverage. And we may also see plans reducing the range of benefits offered in order to control costs. And we'd expect all of these things to have health effects. Some work by Dave Vaness and others has attempted to simulate one of these causal links and to look at these opportunity costs from a US perspective. So they looked at what happens when you have a new technology included in a private insurance package. How does that feed through to premiums? How does that impact on affordability and result in some people becoming uninsured? And what does becoming uninsured mean for individuals' mortality and morbidity? And so they estimated that for every £10 million of additional expenditure, the increases in premiums that were passed on would result in around 1,800 people becoming uninsured, and that would lead to 5 deaths and 96 QALYs lost. And so that data was then used to inform an assessment of the health opportunity cost of private health insurance paying for new pharmaceuticals or other types of care. And that estimated that for every $100,000 spent on something like a new pharmaceutical, there'd be 1 QALY lost. Okay, so I hope to have convinced you that opportunity costs are real and important across different types of systems, though the way in which they occur may follow quite different pathways. Now, this graph shows life cycle value for a new medicine and how that looks over time. So what we see here is net health effects on the y-axis and time from product launch on the x-axis. And so during the patent period, medicines typically achieve a price such that the health benefits of the medicine are more than offset by those health consequences of paying for it. And in fact, Hussein Nati and myself and colleagues looked at this for a large sample of drugs approved by NICE, and what we found was that overall the cumulative population health impact of drugs recommended by NICE over that period was negative, with a net loss of around 1.25 million QALYs. So what that means is if that money that was spent on new pharmaceuticals had been spent on something else, we would have got a lot more health for those monies. But beyond the patent period, we see a different picture. Once generics or biosimilar products become available, we accrue significant value from that innovation. And so it's really important to quantify the losses and the gains from a new pharmaceutical across the life cycle so that we can understand the overall population health impacts of introducing new medicines, and also understand how much we might want to invest in supporting the development of new innovations in the future. So the way that we've structured our consideration of pricing policy is around how value is shared between companies and manufacturers on the one hand, and populations served by the health system on the other. So what do I mean by this? Well, we can think of the overall health effects of a medicine over its life cycle, taking into account any savings or costs and the opportunity costs associated with those, and the costs of production. So we can think of this as the maximum value, the total pie to be shared, if that medicine were available at the cost of production. Of course, new medicines aren't available at the cost of production. We need to pay much more than that for new medicines to stimulate the R&D that brings those medicines to fruition, and we know that that's an incredibly expensive process. So typically, a payment is made to manufacturers throughout the drug's life cycle that's well above that cost of production. And for example, there may be a payment associated with a new product across the product's life cycle, and then we can calculate the health opportunity cost of that payment to the manufacturer. And in this example, we're saying that, well, we get 10,000 QALYs from delivering this new product to the health system if it was available at the cost of production, but we've assigned 4,000 QALYs of that value to the manufacturer as their slice of the pie, and as what we think we want to assign to them in order to appropriately incentivize innovation. So what that means is that the value left for the population, once we've accounted for how much we've spent and the health opportunity costs of that, is around 6,000 QALYs in this example. And so we can use this idea to calculate the proportion of the value of a new product that accrues to the manufacturer and the proportion of value that accrues to populations served by health systems. So we see in this simple example, it's 40-60 split. So the core question that we wanted to address is, well, how is value being shared currently, but also how should it be shared, and how can we think about that in a way that's consistent with an objective of maximising long-term population health? And we can see this as a pretty clear trade-off. If we assign a higher payment to a manufacturer, that's expected to stimulate more innovation with associated long-term health benefits as those innovations are used by the population. But as we assign a higher payment and a higher share of value to the manufacturer, that also imposes a larger health opportunity cost on the health system to fund both medicines already developed and to fund all the medicines developed in the future. So a crucial part of our quantitative modelling on this topic was to examine how we might expect share to feed through to payment, and what are the returns to different levels of payment in terms of stimulating innovation. So how much does paying higher prices for new drugs result in more innovative drugs being available in the future? So to look at this question, we undertook a systematic review of the literature and focused on econometric studies where we considered them the methods to have estimated a plausible or causal effect or a robust causal effect according to some criteria. And these studies typically estimated as their main output an elasticity, and this described the relationship between a percentage change in manufacturer revenue and the percentage change in the number of new products we'd expect to see in the future. So for our modelling, we used a central estimate of this elasticity of 0.45. So that means for every 1% increase in manufacturer revenue, we expect to see about a 0.5% increase in the stock of new drugs. And this was taken from the Congressional Budget Office and some simulation work done by that group. We also use a range of value from the literature, including a study by Pierre Dubois that used IQVIA data and instrumental variables to estimate the causal effect, and a higher value that was estimated by Philipson and Jury by pooling some of the earlier studies. So we use this within our model, and in the first instance, in the results I'll show you, we consider that there's a kind of a single global pricing policy decision, which is obviously a simplification of reality, and would either assume that we had some multilateral policy in place to set pricing policy across different jurisdictions, or that different countries took account of the effects, the externalities, the positive externality of them paying a higher price on benefiting other countries. And I'll show you a little bit later on what happens when we relax that kind of single global payer model. But nonetheless, we think it's very insightful. Okay, so I didn't want to go into the algebra of the model because it would have probably taken quite a lot of the session and perhaps not have been the most helpful for everybody. So what I've presented here is just a very stylistic, intuitive, hopefully presentation of what the model's doing. So what happens when we change the share of value that's assigned to the manufacturer? So as it increases, through that constant elasticity relationship, we also see the quantity of innovation increase. And so we simulate that that will result in higher levels of health gains from existing and future products. But as we increase the share, the health opportunity costs, of course, also increase. So those are the blue bars on this graph. We're giving a larger slice of everything that's developed to the manufacturer. And what the model is doing is working out what's left, because the health gains we get minus those health opportunity costs gives us those overall population health gains. And so what we see is that there's a sweet spot, an optimum, where we can maximize overall population health gains. So that's in broad terms what the model's doing. In terms of what we found through the simulations is that using the evidence I discussed earlier about the relationship between payment and quantity of innovation, we see that the optimal share is in the region of 20%, with a range of 13 to 51% using those different elasticity estimates. And it is very sensitive to the choice of elasticity. We think that on balance, this may be an overestimate of the share, as we don't account for the effects of payment on quality, production costs, and other features like the role of public sector R&D in generating innovation. And I'm now going to move to show you what happens when we apply this framework, looking at the life cycle value of medicines and how it's shared, to 12 NICE appraisals. These were a convenience sample chosen largely because there was enough information in the public domain to allow us to approximate the confidential discounts manufacturers had offered the health system. And that's obviously quite important in getting a real estimate of the share of value going to the manufacturer. And so I'll first take you through the results saying, well, how is value being shared currently under current policy environments in the UK? And then I'll show you the implications of moving towards a 22% share. For this analysis, we use a 100-year time horizon. That might be something we discuss later on. 3.5% discount rate, which is a standard in the UK for economic evaluation in health. And as I've said, we account for confidential discounts agreed as part of the UK reimbursement process. Okay, so these are the products we looked at and their disease areas. And this shows you what's happening under current policy. So we have here the TA, so that's a technology appraisal number. It's a number assigned to each drug that comes through the reimbursement process. We have the product, the disease. The first column of numbers is the product value if that product was purchased at the cost of production. So that's the maximum value to be shared. That's the whole pie for each of these products. We have the incremental cost effectiveness ratio. So that's the cost per QALY that the health system was looking at when deciding whether or not to approve this drug or whether to perhaps ask for a deeper discount. We then have the total reward to the manufacturer across the life cycle in millions, the health opportunity cost of that reward in terms of QALYs, and then finally, the share of value that's going to the manufacturer. And so you'll see that above the dashed line, we have products where those incremental cost effectiveness ratios fall well below what is considered to be good value for money in the UK, which is, well, at the time of these appraisals, it's recently changed, as some of you may have seen, but at the time of these appraisals was £20,000 to £30,000 per QALY. And so for these 4 drugs, we see manufacturer shares that are well below 20% in almost all cases, and one close to 20%. For the products below that line, we saw drugs that were approved kind of right up to where the UK reimbursement process would consider them to be cost effective. So between £20,000 to £30,000, or somewhat higher for the cancer products at around 50,000, as there was some extra policy flexibility in place at the time for those products. And so what we see here is that the manufacturer share is in almost all cases more than 100%. And that's because the health opportunity costs of spending on the new pharmaceutical are greater than the overall 100-year, that long-term value of the product to the health system, even taking into account the fact that we'll have that at generic or biosimilar prices in the long run. Okay, so why is this happening? Well, one of the reasons is that those launch prices are high. If you remember the earlier graph, which had that area which showed the negative net health effects. But there are other things going on as well. So for biologic drugs in the UK, we're seeing it take a long time, and for some drugs, a very long time for the biosimilar to become available. And we're also seeing that once that becomes available, it's often relatively expensive. So that post-patent value isn't as high as it might be if we were looking at a small molecule drug. So there's a range of factors that are resulting in those high value shares. Okay. So what would happen if we were to align payments with the optimal share of around 20 to 25%? So the first 4 columns of this table are what you saw in the last slide. Then we have the reward in millions that would be commensurate with assigning 22% of value to the manufacturer. We then have the health opportunity cost of that pharmaceutical expenditure in QALYs. And then finally, we have the difference in revenue compared to current policy. And so what we see here is that for those first 4 drugs, we'd be spending appreciably more if we were to have a share-based policy. And for the rest of the products we looked at, we'd be spending a lot less if we were to move towards a value share-based policy. So this slide gives some early results from work undertaken by colleagues at ICER in collaboration with York. They've done a lot of work to adapt the life cycle framework that we developed for the UK health system to reflect the more complex price dynamics in the US, both within and beyond that period of patent protection and intellectual property protection. And they've looked at a sample of pharmaceuticals that have both been approved for use in the US and also where ICER had done a cost effectiveness assessment, so where ICER had looked at the value for money of these products. So they looked at 18 products and they found that overall the share of value to the manufacturer was 65%. For drugs that were priced below what ICER considered to be its health benefit price benchmark, so were priced to have an ICER that's less than $150,000 per QALY, the share of value to the manufacturer was 27%, whereas for drugs priced above $150,000 per QALY, the overall value share is 348%. So I think it's reasonable to say that these are qualitatively similar to what we saw in the UK, though of course the products and the exact numbers are different. So one question that comes up in this space is whether we should be thinking beyond population health. So everything I've presented today is very much focused on maximising long-term population health being the primary goal of pharmaceutical pricing policy. And therefore, we care about the pharmaceutical industry, but only in terms of it being instrumental to health by providing more products in the future. Several economists have argued that producer surplus associated with the pharmaceutical industry is also a significant contributor to welfare, in addition to any instrumental role in driving innovation with health benefits. We examined this in our paper as a secondary analysis, and I think there's a couple of things that are really key when thinking about whether we should count producer surplus and how we should count producer surplus when we're designing appropriate pricing policy. The first is that producer surplus needs to account for all the costs, including the expensive and failure-ridden business of bringing drugs to market. And some of the estimates of producer surplus that have been used in the literature haven't done this. They've acted like the difference between the price and the cost of production is all producer surplus, which I would argue is really overestimating producer surplus. We also need to account for the fact that an extra dollar spent in the health system can't be compensated for by an extra dollar of consumption brought about by producer surplus. And the reason for that is that it's really expensive to raise funds to support the health system because of all the distortions associated with raising tax, or in the case of private insurance, associated with administering the private insurance system. When we account for all of these factors and we do include producer surplus, this suggests a modest increase in the optimal share to closer to 30%, but not a fundamental shift in our results. So I also wanted to show you some work in progress where we've been thinking about global pricing policy and about pharmaceutical innovation as a global public good. And this is a feature that's been noted by a lot of commentators and in a lot of the modelling in this space. And this is what kind of drives that concern that smaller markets like the UK and other markets free ride on innovation that's being paid for by the US. And that's really spurred a lot of the policy debate and policy developments, such as the most favoured nation policy we've seen being implemented and developed over the past year or so. So we've recently developed a quantitative model of global pricing that links individual countries' pharmaceutical pricing policies to the level of global innovation and then track the benefits of innovation to countries in the patent and post-patent periods. So we do have a kind of a country by country model. We're not quite ready to share the full results from that. So I'll show you a slightly pared down version of the model, but I think the insights are still really interesting. So here we're going to look at two country groups. So on the one hand, we've got the US, and on the other, we've got non-US high income countries. And we're going to look at a range of different policies. So the first policy is broadly the status quo. The second is where we move towards a more UK-like value-based pricing system. The third is where we have something that looks like most favored nation, which we expect to result in harmonization of prices across high income settings if it's implemented fully. The fourth option is where countries act in their national interest and ex-US countries free ride. And the fifth option is where everybody pays that optimal share of around 22%. And so these are some stylized findings from that modeling. And so what we see is that when we, so we have the policy, we have the price in the rest of the world, focusing on high income countries relative to the US. We have an assessment of the impact on the number of new drugs developed, and we have an assessment of the long-term health gains per drug developed when we account for health opportunity costs. So what we see is that moving from the status quo to having a more HGA-based, value-based pricing policy, where we do take account of the health opportunity costs of expenditure, would mean that the rest of the world paid much less for pharmaceuticals than the US, and it would reduce the amount of new drugs developed, but it would improve health gains per drug, accounting for health opportunity costs, which I think is really interesting. Because even for the US, the US might well be better off getting fewer drugs, but getting them at a more sustainable price and using the money saved to provide other forms of care, ensure that more people are kept within the envelope of health insurance, etc. We then look at the impact of harmonizing prices via an MFN type policy. Here we have a smaller reduction in the number of new drugs developed. And we see that the US does better, but the other high-income countries do much, much worse because they're paying so much more for their drugs. And in fact, they'd be better off just not buying the drugs and using those monies for other purposes. When we look at the option where countries act in their national interest and ex-US countries free ride, we see the lowest level of number of new drugs developed of the situations we've modeled. And we see the US do worse than under some policies, but not worse than under the status quo. And the high-income countries do the best of all options. So the free riding, although it reduces the supply of innovative drugs in the future, it also allows the US to act in its national interest from a population health perspective and reduce its pharmaceutical expenditure. And then finally, we have the scenario where countries contribute the dynamically optimal share. Again, we see price differences and reduced innovation compared to the status quo, but we see that both countries do better than under the status quo. So I think these results are quite interesting in highlighting that less innovation isn't always worse, and free riding isn't always worse, even for the US, if it means that the US can regulate prices much more strongly. So I'm keen to wrap up and hear any comments or questions. So I'll give a brief summary and policy implications. So what we found by looking at life cycle value is that the long-term value assigned to manufacturers, both in the UK and the US study, often exceeded 100%. And that means that these approvals are reducing population health over the life cycle, even when we take into account all those post-patent benefits from having generics and biosimilars. And that's driven by high prices, the long periods before those generics or biosimilars become available, and for biologics that they can be quite expensive. I think this really highlights that, as well as thinking about price per unit or price per patient, we need to think very carefully about overall reward across the life cycle and ensure that we're managing that appropriately via pharmaceutical pricing policies. If we were to better align reward with an appropriate share of value, that would increase overall population health, even when we think about the long run and effects on innovation. And it would also provide more appropriate incentives for innovation. Just summarize 3 key limitations. The first of these is that when we've looked at the effects of different pricing policies, we've restricted effects on the quantity of new drugs available, whereas the available evidence and theory suggests that higher payments also result in reduced quality and reduced product novelty, so more Me Too type products, and lead to products with higher costs of production. We've assumed a constant elasticity relationship between payment and the number of new drugs available in the future. That was informed by the available evidence, but of course it is a structural assumption. And finally, we haven't looked at the effects of price on access, and that's obviously a very important part of the story, both in terms of systems where co-pays may be in place, and they may create a link between price and access, but also in systems like the UK, where we may see higher prices resulting in reimbursement being restricted to smaller populations. So thanks very much for inviting me to the talk and for listening to this. I just wanted to highlight that this is our website, which holds a lot of our medicines pricing work, and to encourage you to take a look. Thanks.